Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
Hello, and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gill, the host of the documentary Open Your Eyes. Please visit the film's website at openyoureyes2020.com, featuring interviews with more than 50 optometrists from around the country, sharing information on eye care and eye disease. If you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, leave comments. There are close to 300 systemic disease states that can manifest in the eye. New technology in eye care allows the optometrist to examine the body's tiniest blood vessels. This allows for the earliest detection of systemic disease states, such as prediabetes, diabetes, and other vascular diseases. Detecting patients early on the diabetes spectrum can prevent or delay the development of diabetes and all its complications. Today's guest, Dr. Craig Thomas, is an expert in subclinical eye disease and has connected the dots between subclinical eye disease and early detection of systemic disease. Dr. Craig Thomas is a noted educator, lecturer, and author. He practices optometry in Dallas, Texas. Welcome, Dr. Thomas.
Well, thank you, Kerry. Good morning. Glad to be here.
Well, thank you for doing this. So, Craig, let's get into it. What has changed in eye care that allows the optometrist to be able to diagnose disease so early?
Well, there's two things, Kerry, that have changed. The first is technology, and the second is information. They basically go together. You don't know which one comes first, the chicken or the egg. But for me, they're almost running a parallel course. So as I obtain newer and more advanced technology, I seem to gather and learn more information at the same time. So we have a lot more knowledge than we had 5, 10, 15, 20 years ago. And the technology has exploded, almost like NASA space shuttle, where every year or two, it seems there's something new and innovative that gives us a different perspective on how to look at the eye and look at the body and take care of our patients. So those are the two big things, Kerry, is the information is exploding and the technology is exploding.
The eye is an incredible biomarker to help not only diagnose eye disease, but systemic disease. In fact, there's over 1,000, there's over 100 autoimmune diseases, and almost every one of them affects the eye. How can we use the eye as a biomarker for systemic disease?
Well, there's two primary things that I use, and it's one is the retina. We're looking at the retina. The retina is nerve tissue. So if everybody that's listening out there, go back to your basic high school anatomy, think of your brain. The brain is part of the central nervous system. You've got cranial nerves that come off of the brain. The optic nerve is one of those. The optic nerve comes off the brain, goes into the back of the eye. And as eye doctors, as optometrists, we're privileged to be able to look at a part of the body that is so unique that there simply is nothing like it. We can look at nerve tissue while it's alive in real time and real space. We can look at blood vessels inside the body, not on the surface, not on the skin. We can look at vessels coming out of the nerves, blood vessels coming out of the tissue. We know what it's supposed to look like and what it looks like when it's abnormal. So those are the two biggest things, Kerry, is looking at brain tissue, at nerve tissue in vivo, just in real life, and looking at the blood vessels and making assessments about the person's vascular health by simply looking at the blood vessels in their natural state, because we're the only ones that can do that. Eye doctors, there's no other doctors that look at the blood vessels in their natural state without cutting or doing something to get into there. So we've got unique opportunity and a unique skill set. And when you put those together, it's beneficial for our patients.
What is subclinical disease?
Subclinical disease is basically disease that you don't know you have, that is there without signs or symptoms. So basically, if you had to condense it down, it's a person that has some disease process going on and they don't know about it. They don't have any complaints and they don't have any loss of function. So no signs, no symptoms. There's all kinds of diseases that present like that from start to finish. And most diseases present like that in their early phase, what we call the natural history of the disease. So you think of most diseases kind of in a beginning, a middle, and an end. So that's the natural history. How does the disease start? What does it look like when it's kind of get going? How does it look like when it's really advanced? And you know, doctors are trained to diagnose disease at any stage of that presentation. But for most of the patients and most of the time, the easier it is for the doctor to make the diagnosis, the worse it is for the patient. You know, the example I use with my patients is if the guy comes in complaining of chest pain and coughing up blood, you know, and we find out he's got lung cancer, you know, he's got 3 months to go. That's advanced disease. If we caught that thing 3 years earlier, we probably could save it. Well, most diseases like that. If you catch it early before you have a severe loss of function and structure, it's almost always better for the patient. You know, that's about as simple as it gets. What's changed now, again, like we said in the beginning, the technology and the knowledge has changed. So the patients have always presented to our offices in all of these various stages of the natural history. Some people with early disease, some people with moderate disease, some people with advanced disease. We usually would miss the early disease because of a lack of knowledge and technology. In 2020 and going into 2021, that's just not the way it is anymore. And we just need to get the word out to the patients and the doctors to increase the utilization of the technology and to increase, to continue to learn even as we are out of school for years and years and years. So, you know, we just still have a lot of work to do, a lot of improvement to make, but there has been a lot of work already done and a lot of improvement made. Patients that come to my office, patients that come to your office, they are receiving top of the line, can't be no better care. We just need to get the word out like we're doing now. So if someone's listening to the podcast and they happen to be going to an eye doctor that is not practicing at the top of the ladder, then you know they might want to raise their hand and say, "Hey, doc, I heard this podcast. You might want to think about doing this." And, you know, we'll see. We'll see.
You know, there's unbelievable technology. You know, when I went to optometry school, and probably when you did, we used to look in the back of the eye with an ophthalmoscope, and the resolution was about 100 microns. Now the resolution with these special cameras that we have are at 10 microns, 10 times the resolution, allowing us to diagnose systemic disease and eye disease much sooner.
Absolutely. I mean, I think one of my scanning lasers goes down to 7 microns. I mean, I actually called one of my retina specialists when I was contemplating the purchase, and I said, "Hey, I'm going to get this new instrument. What do you think? You know, and how does it compare with the one you got?" And he goes, "Well, you know, the one I've got goes down to 10 microns." And I go, "Well, the one I'm looking at goes down to 7 microns." He goes, "Well, if you really think a 3 micron difference is going to make a difference in us making decisions, knock yourself out." I mean, we're down to the point of arguing about microns, you know, 1,000th of a millimeter. So, I mean, the technology is really advanced at looking at the back of the eye, the retina, the nerves, the different parts of the retina, the blood vessels. You know, we can kind of start talking about the newest thing that you and I use, what's called OCTA, optical coherence tomography angiography. So most people that are listening have probably heard of angiography or angiograms. These are tests that you use to measure the blood flow inside the blood vessels inside the body. Ordinarily, you would have to get an injection of dye, and then you would use some kind of special imaging, you know, the fancy MRI clinic, and do an MRA or Doppler ultrasound, you know, some type of invasive testing. You know, anytime you're getting an injection of dye into your body, that's by definition an invasive test. So ordinarily, historically, when doctors wanted to get information on blood flow and blood perfusion, the amount of blood flow going into the tissue, you would have to do fairly sophisticated, invasive, expensive, uncomfortable, and somewhat risky testing. We don't have to do any of that anymore. Now, and not now, for the past several years, if patients come to an office like mine or like yours, You have the ability to obtain information on the person's vascular health with these sophisticated OCTA retinal imaging scanners. And I can now, in 5 minutes, tell a person whether they are, you can't really make the definitive diagnosis without the blood test, of course. But in 5 minutes, I can tell a person that they probably have diabetes. Okay, I can do that. If the diabetes has been there for a while, if it's been there for a few years, I can do that. You can do that. The thousands of eye doctors in this country can do that right now if they have the technology and the knowledge base. So that's a big thing, is the advent of this new, what's called OCTA technology. So for everybody that's listening, you need to ask your eye doctor, Dr. Smith, do you have an OCTA device in this office to check the vascular health of my eyes? Yes or no? That may be an uncomfortable conversation, but if the patient has more knowledge than the doctor, the patient might need another doctor. I don't know.
So the OCT angiography now could pick up disease much sooner than we were able to pick it up the traditional way. In fact, there's been studies done on that. What are the percentages that it shows that OCT angiography could actually pick up before we can with classic techniques?
Well, what we're talking about now, Kerry. Let's almost back up one step. We're talking about now primarily people with diabetes coming into their eye doctor to have their annual diabetes surveillance eye examination, correct? And almost everybody that has diabetes knows the protocol. They know the rules and the regs. Their medical doctor, because it's in their best interest, wants them to go get an eye examination once a year. At a minimum, the eye should be dilated for the examination, generally speaking. And the eye doctors, me and you, and all of our colleagues, are charged with looking inside the person's eye and seeing if they have developed any complications from having systemic diabetes. So in this group of people, we know they have diabetes. We're not trying to see whether they're healthy or not. We know they have diabetes. The question for us is, do they have complications associated with the diabetes? Now, what you and I know is that in 1989, all the doctors that are charged with doing this kind of stuff came up with rules and regs and guidelines that we call early diagnosis treatment study. It was a bunch of studies going on, but it was 30 years ago. And what these the studies determined is that we are supposed to look in a person's eye, look in the different parts of the eye, and essentially, basically, try to determine, is this person's eye bleeding, yes or no? That's if you had to condense it down. What's the goal of the exam for the person that has diabetes? We're supposed to determine, is this person's eye bleeding, yes or no? That's 99% of what we're supposed to do. Now, there's a few other things we're looking for that are associated with diabetes complications, but the vast majority of it is bleeding, the hemorrhaging, all the things that we look for, microaneurysms and all the different types of vascular abnormalities. So we look in the person's eye, we dilate them up. Every person that's listening that has diabetes and has been to the eye doctor knows the protocol. You sit in the room while your eyes are dilating in the dark. The doctor comes in, shines really, really bright lights at you. It's really uncomfortable. And then while you're still dazed, he or she will say, hey, you're okay. See you next year, when it's all over. That is a way to do it, but that's not the best way to do it, because what we know now is that you can have clinical signs of diabetes, complications from diabetes, 2, 3, 4, 5, 6 years before your eye starts bleeding. Kerry, you're one of the leaders in the country that have identified pre-diabetes and insulin resistance using multispectral imaging technology. I mean, there's only 200 doctors in the whole country that have that technology. You and I are one of those two. We understand it, and we're trying to share the word. But this OCTA looks at it a different way, and for good or bad, there's thousands of these things out in the country as opposed to a few hundred of the devices that we also have. So, we got to move forward, I think, with the OCTA technology for the masses for now. And so what I have seen, what you've seen, what hundreds of doctors have seen, what has been now written up for several years in the literature, is that it is very likely and very possible that people that have diabetes will show what we now call subclinical changes, changes that cannot be visualized with traditional examination techniques. That is the definition. It's a fluid definition. So traditional examination techniques are designed to detect bleeding in the eye secondary to a person having diabetes. Well, I'm changing tradition in my office just like you are. And the tradition in my office is to do OCTA imaging and multispectral imaging in addition to simply looking at the eye. So I'm going to look at it. I'm going to see if it's bleeding. But if it's not bleeding, that does not guarantee that there's nothing wrong with them. As a matter of fact, that you asked the question, what's the percentage? The 2 or 3 articles that have actually studied it approximate the percentages at about 35%, depending on the study. So it might go up to 30, it might down to 30, up to 40, but just say 35%. So if you line up 100 people that have diabetes, they go to the eye doctor. They're there to see if they have any complications from diabetes. That's what they're there for. 100 people. You dilate them all up. They're sitting in line waiting to get examined. The eye doctor goes in and looks in there. And out of that 100 people, not one of them has any bleeding. Not one of them has any swelling. Not one of them has exudative formation, the regular stuff that we are trained to look for and identify and then communicate that finding to the patient and their medical doctor. So you line up 100 people with diabetes. And out of that, and again, you wouldn't have that in real life, but for the sake of this conversation, out of that 100 people, not a single one of them has a drop of blood in the back of their eye, which is the most traditional complication that people are worried about, bleeding in the eye. If you examine them with more sophisticated, advanced technology, OCTA imaging, multispectral imaging, and again, I don't know the stats on the multispectral, probably haven't done one, but the stats on the OCTA is 35%. And you will find 35 people out of that 100 that have changes in their blood vessel health, in the structure of the capillaries, something you could see, something you can measure. It's there. All you need is the right technology to see it. It can't be a $200 ophthalmoscope like you saw in some Norman Rockwell painting in the 1950s. It needs to be a $50,000 or $60,000 OCTA retinal imaging device if you want to see if there's something wrong with you. And what you find out is that out of those 100 people where you thought they were normal, well, 35 of them had something wrong with them. So if you don't have the right technology, and if the doctor doesn't have the right knowledge base, he or she is going to make an incorrect diagnosis 35% of the time when they line those 100 people up and they'll say, so the patient's getting dilated, they finish the exam. Dr. Thomas, is my eye okay? Yeah, you're fine. See you next year. Next patient, Dr. Thomas, is my eye okay? Yeah, you're fine. See you next year. I'm gonna send a note to your medical doctor, tell them you're fine. You don't need to change that diabetes treatment and all. Everything's okay. You're great. You're good. Don't change nothing. Okay, if I did that to that 100 people, I'm gonna be wrong 35 times.
Talk
If
about
you don't have the technology, you're gonna be wrong 35 times.
Talk about vascular density. And that's what the OCT is so great at. The OCTA is so great at.
It is really, really cool. So the vascular density is simply a metric or a measurement that the instrument calculates based on basically the density of the capillaries within a set amount of tissue. So if you can imagine taking a little square tissue, a little 1 millimeter square of retinal tissue, and then there should be X number of capillaries running through that thing. If there's a lesser number, then that density number goes down. And we have established normative databases for those values. So we know what a normal vascular density is versus what an abnormal vascular density is. And again, it's one of the most important things that I show the patients, and one of the most significant things they key on, because we can change it. And I've already changed it in people by getting them healthier. So I've got people where we put them on nutritional supplements, change their diet, get them to go weight loss. I've seen it change in 6 to 12 months, where you can make people healthier if they want to be, and you can show it to and measure it. You've heard me lecture on this topic, and I always use one of my favorite patients, I love this guy. He was actually in last week. I got a new Claris demo and I had him come in. And this is the guy you heard me talk about him, because if you have poor blood perfusion in the back of your eye, if your blood vessels are damaged because you have diabetes, and diabetes is a disease of the blood vessels. So if it's a disease of the blood vessels and it's a disease of the nervous system. Those are the two main target organ systems. And so if you've got low blood flow to the back of your eye, it's affecting your vision. You can't see well. I can measure it. Well, it would be almost impossible to suggest that you would have abnormal blood vessels in the back of your eye, in the retina, and not have abnormal blood vessels anyplace else in your body. I mean, that's just nonsense. And so whatever happens in the eye happens in the body. That's one of the things you've been talking about. I can see the blood flow going down in your eye. Well, I know it's going down in your kidney. I know it's going down in your heart. I know it's going down in your brain. Might get a little early Alzheimer's going because your blood flow to your brain's not right. Okay, it's not isolated to the retina. The eye is the window to the body, and eye doctors are the guys that are doing the looking to see what's going on. We're the first ones in there trying to figure stuff out. So, what's the significance of it? I have seen in more than one patient where decreased blood flow, decreased ocular perfusion that I measure with my instruments. When I start asking questions, hey, do you have any other problems in areas that are connected to blood flow? And especially with men, you might be surprised at how often you get a response. And I'm like, well, if you get this better, that might get better too. Let's get to work on this with the proper motivation. And when you put it to a patient like that, you'd be surprised how motivated they get. And when you can show them the numbers, and especially when you can show them their numbers getting better, like, hey man, your blood flow is getting better, keep it up. If you lost 20 pounds, you're taking the supplements, you're eating breakfast, we're doing the right thing. You can't medicate your way out of it. You can't take more insulin to fix this. Okay, you got to do it the right way. And I've been able to help quite a few of my patients do it the right way by using this information as a motivating tool to show, hey, this is where we're starting, this is what we're dealing with. Look at how the blood flow over here is not really strong. This is the plan. I want to see you back in 4 months and let's get to it, okay? And it really works good when you can show it to them like that. So, you say, what's the significance of the blood flow and tissue perfusion? It's just an eye thing, and, they can still see okay. Well, yes and no. Again, I just told you, if it's happening in your eye, it's happening in your body. If your eyes are healthy, your body's pretty healthy. If your eyes are sick, yeah, you might be sick too, okay? They do go together, and you know that.
Yeah, the eye bone's connected to the toe bone.
The eye bone's connected to the toe bone.
And it's really incredible because now the technology is so good that we could pick up disease so early, or preclinical disease so early, that we could reverse it. And that, like you said, you have patients, and I have patients. We change their lifestyle, and now the blood vessels come back. For most disease processes, as you know, glaucoma is one of the prime ones. It's a gradual, slow process to kill something, to damage something to where it won't recover. That usually takes a while. And so it's kind of a, without sounding gory, it's kind of a slow death. Well, because it takes a while for nerve fibers and stuff to die, if you catch them actually before they die, if they're not, too far gone, they can get better and you can get recovery. We can get recovery in optic nerve fibers with treating glaucoma. We can get recovery in meibomian gland dysfunction by treating meibomian glands. We can get recovery in blood vessel density by increasing the person's overall physical health. We can make people better if we catch the disease process early in its natural history. I can't fix somebody with gangrene, but I can fix them if they look normal, and I use my fancy machines to really see that they're not. I can fix them real easy then. It's real easy early. And as doctors, we're not really used to that. We've been trained that once something is wrong, it's wrong. We just want to try to prevent them from getting worse. We're not used to them recovering and doing better.
Well, as you know, Carrie, and you've been the leader in this in our profession, one of the leaders, our whole health system's based on fixing sick people, not making people healthy. All the money's in disease, not health. I
Yeah.
like all these guys with diabetes. I say, well, I'm already taking 2 pills of insulin. I go, yeah, that's the problem. Okay, yeah, we're gonna go backwards. We're gonna get off of this stuff. More health, less drugs. It works fine, and it works fine. It works fine. It works just as good. Food is like medicine if you have diabetes.
We're used to treating symptoms, not treating cause. And now with this technology, we could treat the cause. We could start talking about lifestyle.
Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using mesozeaxanthin, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
Thank you for tuning in to the Open Your Eyes podcast. If you like the video you're watching, please hit the like button. Also, hit subscribe for weekly new episodes of the podcast, along with pod winks and bonus content. All right, let's get back to the show.
We talk about classifying diabetes, back from 1989, but you proposed the Thomas classification of diabetic retinopathy. Talk to us about that. I think that's fascinating. And
well,
I love that.
I actually called a couple of guys to see if it had a chance of getting some traction, and they lauged at me. They said, "Man, you're hallucinating. Stop."
I love it. I love it.
I thought it was great. Because it's accurate.
And when I send to the PCPs and the endocrinologist when I have a diabetic patient, I use the Thomas classification to tell the doctors what's wrong with their diabetic patients when it comes to the eye.
I tried to. They didn't understand it. Once I went past bleeding of the eye, they just tuned out. So, we haven't even talked about this yet, Kerry. So, you asked me several minutes ago, about subclinical disease, okay? And we're kind of concentrating on people that have diabetes, but there's a little bit of overlap and extra stuff that goes with that. So the second biggest thing that I see in my office, and you see it too, we don't talk about it nearly as much as I think we should, is the neurodegeneration, okay? Nerve damage, okay? People with diabetes. Think about if anybody out there listening got diabetes, okay, listening to the podcast right now. I've been practicing optometry for 35 years, I think. And I have lost count of the thousands of times I've had people with diabetes come in my office, and I'll say, "Hey, Ms. Jones, how you feeling today? You okay?" "Yeah, I got a little tingling in my fingers and my toes. It's kind of painful a little bit." I said, "Oh, I'm sorry to hear that, Ms. Jones. That tingling in the fingers and toes." Okay, Kerry, how many times you heard your patients complain about tingling in the fingers and toes?
Sure.
Okay, what is that?
So
peripheral neuropathy.
And now we could see it in the eye. You're going to tell us how we could do that.
I could see it in the eye. I could see
technology now that could tell us if somebody.
I could see it. Okay, so what I do now with my patients, different than, well, I've been doing it for a while. If you remember, Kerry, the very first time I started talking about this was at the All Docs meeting when we went to the Broadmoor in Colorado, and I did that OCT lecture. That was the first time that I started talking about it. And I think that was like 8 or 9 years ago, man.
Yeah, man.
That's when I first got wind of it, where I'd start seeing people with diabetes, and I do scans on them. And we've been trained and fixated on looking for what's called diabetic macular edema. That's the #1 cause of vision loss in people that have diabetes. That's the most serious complication for most people. And that's when the fluid is leaking in the retina, and the retina is swelling up and it's too thick. And sometimes you can actually see it just looking at it. And it's usually real easy to see with these fancy OCT machines that we have. So we're always looking for increased retinal thickness. That's the sign, the marker. And then, you have to figure out why it's thick. If the person has diabetes, that's the #1 reason. Alternatively, but what has much less emphasis, is what if the retina is too thin? Okay. So, the retina, it's like Goldilocks in the porridge. Is it too hot, too cold, or just right? So is the retina of normal thickness, and you assess retinal thickness as a reflection of retinal health. So that's an indirect measurement of retinal health. is measuring retinal thickness. So a person that has diabetes, you measure the thickness of their retina. It should be within a certain range, and then you call them normal. If it's above that range, then you say the retina is too thick or swollen or edematous, and, and that would be a complication. What if it's too thin, Carrie? So if it's too thin, what you have is an atrophic process where the nerve fibers are dying and almost like a sponge dehydrating and losing water, getting thinner and thinner and shrinking. So when the retina decreases in thickness, it is dying, it is atrophying. There's some disease process that is negatively affecting it. That is the most abnormal finding and most uncommon, unless you have diabetes. And what the literature says is that 18% of people that have diabetes manifest their first complication as decreased retinal thickness, what is called neurodegeneration. The nerve fibers are dying. The diabetes is killing them. I'm not going to get into the mechanism. We almost don't understand it, but that's what's happening. And just like the diabetes damages the nerve endings on the tips of the fingers and toes and produces this tingling, burning, like you're walking on glass kind of thing is what people say sometimes. Well, that's nerve damage. Nerve damage is called neuropathy. So we've got back to the brain, the nervous system. We're talking about nerves now, neurodegeneration. The nervous system is basically broken into two divisions. You've got the central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, all the other little nerves that come off and extend all throughout the body. And kind of the further away they go from the brain, the thinner and longer and more fragile they get. So the fragile nerves are usually the first ones to go, and those are the ones furthest away from the brain. That's why people, they don't say they got tingling in their elbows and their shoulders. They got tingling in their fingertips and their toes, the stuff that's furthest away, the long, skinny, fragile nerves, they go first. So think about it in just a common sense mode. You don't have to be a doctor. If you've got nerves that are damaged down in your tippy toes, and the nerve started in your brain, the brain is the central nervous system. The nerves way down in your tippy toes are the peripheral nervous system. Logic demands, common sense says that any kind of nervous system problem is going to probably start in the brain and then work its way down, as opposed to something starting in the toes and working its way up. I said at the beginning of this podcast, think about it. The cranial nerve, the optic nerve, the nerve coming off the brain that goes into the back of the eye. As eye doctors, we looking at the brain. We're looking at brain tissue when we look inside the eye. The retina is part of the brain. If the retina is damaged, the brain is damaged because they're the same thing. We've got technology and instruments that allow us to really evaluate the brain. That's what we're doing.
And the thinning that you talked about that tells us about the neuropathy within the eye, that's what instrument are we using for that?
We're using the OCT without the angiography component, just the traditional OCT that's been out for 10, 12, 15 years that most eye doctors have, okay? So that's a big thing because again, you can look normal you will. So let's say you don't have any bleeding, you don't have any vascular abnormalities. So let's go back to that same 100 people that we talked about a little while ago. You got 100 people with diabetes coming in. There's 100 people listening to this podcast right now with diabetes, and they all go to one office. Okay, we're doing a study. Everybody gets dilated. We're trying to see if there's any complications from diabetes. We're doing a diabetes surveillance eye examination, okay, designed to detect the presence of any complications from diabetes. We dilate them up, look inside, not one drop of blood, no swelling, no nothing. They look fine. They are totally normal in appearance, okay? We do OCTA retinal imaging. 18 of them are going to have retinas that are thinner than normal. That's what the literature says. And that is subclinical diabetic retinopathy. By definition, they have diabetic retinopathy. It has not progressed to the next stage in the natural history where they're going to start bleeding, okay, where we're all cued in to raise our hands now. So we're trained to not look for the first step and to raise our hands at the second step. Whereas you and I know to get to the second step took 8 years. And we could have intervened long before then.
Talk about electrodiagnostics and how that could help us with nerve disease.
The electrodiagnostics is a special type of functional testing. So when we do tests, so sometimes doctors can look at people and look at patients and I know exactly what's wrong with you. I can do a clinical examination where I just look at you and I can figure out what's wrong with you. If I need to run some tests to figure it out, then I'm gonna do a physical exam. That's the difference. So clinical exam is the doctor just looking at you. Physical exam is running a bunch of tests. The tests are designed to evaluate structure and function. So a simple way of, let's say I fell on my arm and I got up and my arm was hurt real bad. And I would wonder if I broke my arm. I looked at it, it looked okay. What would be the first test I might do? I might do an X-ray. An X-ray would evaluate the structure of my arm, and it would show me what I couldn't see with the naked eye. So that structural evaluation for us is this OCTA and OCTA technology that we've been explaining to people listening. So we're doing a structural evaluation there. Let's say, I fell and hurt my arm. I got up, my arm's really hurting bad. And I wonder if I broke my arm, I can't, it looks okay. I'd have to have an X-ray to evaluate the structure, but I could also make some kind of assessment by evaluating the function of my arm. So let's say the function of my arm is to reach over and pick something up like you see here. So here I am using my arm, I'm using the function. If my arm was really broken, the function would be impaired. I wouldn't be able to do this as well, not as fast, if I could do it at all, if my arm was broken. So if you measure function is a way to see if the person's normal versus abnormal, just like measuring structure. Electro-diagnostic testing is a way to measure function without asking the person any questions. That's a big benefit. So it's an objective test where I don't have to ask you any questions. There's two things that people seem to dislike going to the eye doctor's office. One of them is getting puffed in the air, and the other one's answering questions. It's like they come in, Dr. Thomas, you're not gonna puff me with that air puff machine, are you? I go, yes, I am. Okay, just sit still, be quiet. Okay. Kerry, how many times you heard that? You're not gonna puff me, are you? I don't want to get puffed. So they don't want to get puffed. And then you put them in the exam chair, we get ready to check their vision. Dr. Thomas, you're not gonna make me answer those questions, which is better, one or two? I go, well, yeah, that's exactly what I'm getting ready to do. Why you've been here before, that's what I'm gonna do. Well, I don't want to do that. I go, well, look, we gotta do it, okay? We gotta do it. So I gotta ask questions, you gotta give me an answer. Well, that's a subjective test. Some people don't like doing that. Some people just want to sit there and let me do all the work. Okay, well, that's an objective test where you just kind of sitting there. So electrodiagnostic testing is a way to measure visual function without you having to answer any questions. And what you do is it's pretty simple, pretty quick with the technology we have. It measures it measures the strength and the speed of the electrical impulses going through the tissue after they've been stimulated. That's what it does. And just like with all the other tests that we can do, it has the ability to detect subclinical disease. So again, I can have that same 100 people with diabetes, the same 100 people that look totally normal. I say, hey, can you see fine? Yeah, I see okay. Then I'll do this, I'll do what's called an electroretinogram and measure the function of their retina, and the function would be decreased. And I'm like, hey, you're not as okay as you thought you were. Okay, what'd you have for breakfast? Okay, I mean, that's my cue. As soon as I, hey, when's the last time you went to the doctor? When's the last time you checked your blood sugar? Tell me now, come on. So, I mean, if I see any decreased function, because again, just like we're keyed and trained traditionally to simply look for bleeding, from a function point of view, we're trained to identify what's called visual acuity, what everybody knows as 20/20. So if you have 20/20 vision or 20/20 visual acuity, then traditionally we say your visual function is normal. What we know now is that you can have normal 20/20 visual acuity and abnormal color vision and abnormal retinal sensitivity, abnormal contrast sensitivity, abnormal dark adaptation. There's 5 or 6 ways to measure a person's vision, what's called different domains. So I can measure your vision in one domain. I can measure it in a second domain, a third domain. The measurement of visual acuity, which is what most of us do at the eye exam, is simply one domain. And everybody's different. So you might have, 10 people with diabetes, 5 of them have complications. The first one may have decreased visual acuity, normal color vision. The second one might have normal visual acuity where they still see 20/20, but you measure their color vision and it's abnormal. Well, that's abnormal then. The 20/20 means nothing. They have decreased visual function secondary to diabetes. Well, that's a big deal. And just because it's not visual acuity doesn't mean it's less important. There is damage to that person's neurovisual system, and it is our job to identify it, educate the patient, and recommend a treatment program designed to help them get better. And that's what we do.
And which is so amazing because we could pick up diabetic neuropathy, we could pick up diabetic retinopathy way before there's bleeding, where we could intervene with your 5 steps that you spoke about before, help these people so they don't advance where they get bleeding in their eyes.
And I got to tell you, Kerry, I spend, just like you, a good portion of my day talking to people. I've got an army of staff that can, do this and do that and run this machine and this is if people don't understand this stuff, it's really hard for them to get better. And it's very satisfying. And I hear it on a regular basis, just like you. And I'm hoping that people listening to the podcast can understand. But on a pretty regular basis, I hear from my patients, man, I didn't know eye doctors did this kind of stuff. I didn't know you knew all this stuff. I thought you were just an eye doctor. I go, I am an eye doctor. This is what eye doctors do. Because, and they're listening, their jaw, they got to pick the jaw up off the floor. And it's like, hey man, I'm trying to help you. This is what modern eye doctors do. I'm a modern eye doctor using modern technology, incorporating modern, up-to-date clinical knowledge. And when you do it like that, this is how we roll. It's better for us, it's better for them. It's just my only concern, just like you, is doctors like us are kind of still in a small group, unfortunately. We are not the average yet.
Soon to be the average.
Soon. Keep hope alive.
Soon. So there's a new test that I have that you recommended many years ago, but now it's been improved a lot, where we could test pupils, where the doctor doesn't have to check the pupils. An instrument could check the pupils, and they could check it, and the instrument checks it better than we can. Talk about that instrument.
That instrument is called eye kinetics. So it's a, I don't want to get too geeky doctorish. It's an automated pupillograph. So it's a device designed to measure pupillary reflexes. So the pupil is the little black hole right in the center of the eye. So if you've got a blue-eyed person, you can see the black hole right in the center. If the person has dark brown eyes, it's kind of hard to see it, but it's always there, of course. And the job of the pupil is to regulate the amount of light that comes in and out of the eye. So when the light is real bright, the pupil will constrict down and get real small. When it's real dim, like at nighttime, the pupil will dilate and open up and let as much light into the eye as possible. That mechanism, those pupillomotor reflexes, the constriction and the dilation, is controlled by the different little parts in the brain and pathways in the brain. So it's a neuroanatomy thing. It's a pathway. So there's a pathway in the brain, kind of the highway that connects the brain to the pupils and makes the pupils constrict up and down. So it's all a little network there. Now, ordinarily, traditionally, the way we've been trained to assess whether the person's pupillary reflexes are normal or abnormal is to simply shine a light in the person's eyes and observe the response. And it would be something we've all been trained to do. It takes a few minutes, a minute or two. And if the person has something wrong with them, and there's 5 or 6 or 7 fairly significant things that can make a person's pupillary reflexes abnormal, part of what we're supposed to do is trying to see if our patients are healthy. Do they have anything wrong with them? And I've diagnosed probably 12, 15 brain tumors in my career. And I've been doing this a long time. So, I mean, I may go a year or two without doing it, but I've done it 12 or 15 times. And so if somebody comes in with a brain tumor, it's my job to tell them, hey, you're normal, or hey, you might have a brain tumor. That's my job. And I can't just be selling a pair of glasses, because if they have a brain tumor and they came in my office, I am responsible for telling them they got a brain tumor. Whether it's an easy one or a hard one, that's my job. Well, checking a person's pupils is one of those ways to do that. And so it's measuring. It is another way to measure visual function. So let's say the person had a brain tumor. Okay, if it was off to the side and pressing on one nerve, one eye might be clear, one eye might be blurry. Okay, well, that'd be a pretty easy clue, and it wouldn't take too long to figure that out. But what if it was not like that? What if it was a little small tumor? What if it was barely getting going? What if it was in the middle instead of off to the side? So the 20 different variations to where the vision might have been fine. They might not have had any headaches. It may have been subclinical, which means they wasn't complaining and they didn't have a loss of function, not yet. And the only thing that may have been abnormal in the early stage of the disease might have been the pupillary reflex. If it was real subtle, I might have missed it. It's a hard thing to do. It's not something we really concentrate a whole lot. So make a long story short, once technology became available for me to replace me picking up a $10 flashlight and swinging it back and forth, I said, let me do what I do with all the other aspects of the way I take care of my patients. Let me use technology that is what I hope one day will be traditional, but is now advanced, and let me improve the quality of care that I deliver. So I acquired the technology. And Gary, I must tell you, I'm sure you've noticed it too. I mean, there's not a month goes by that I don't pick up some person with some disease that would have easily been missed through traditional examination techniques. I actually had a couple of weeks ago, a week where I picked up 3 normal tension glaucomas in 1 week. 3 patients with glaucoma. I'm sorry, normal tension glaucoma is the hardest type of glaucoma to diagnose, where the person essentially has no abnormal signs at all. They ain't complaining about nothing, and very few abnormal symptoms. Again, it's hard to diagnose that disease early. This technology allows me to do that, and what it does is it picks up the difference in pupillary reflexes between one eye and the other, and that's a sign of disease. It takes a minute or two to do the test. The only reason that probably every eye doctor in the country doesn't have one is because they're expensive. Okay, I mean, all this stuff's none of it's cheap. It's all expensive. So your eye doctor has to want to practice like this, and unfortunately, not everybody's there yet. But almost, again, kind of being facetious and comical, anybody that's listening to this podcast, it'd be kind of funny, next time you go to your eye doctor, hey, Dr. Smith, I heard this podcast and these 2 eye doctors were talking about this machine that called the eye kinetics that can check your pupils and see if I got a glaucoma case or brain tumor or anything. You got one of those down the hall? You could run on me? Y'all got one of those around the corner? It'd be kind of curious to see what the eye doctor would say if he didn't have one, if he or she didn't have one.
I had a patient yesterday who was a 36, so 35 is kind of the cutoff. That's the number we use for somebody being abnormal. 30, 35, and
yeah,
and the person had a midbrain stroke.
Wow.
Bad, he had a poor gait, and he had trouble walking, and
so you might have figured it out, but that made it so easy.
Made it so easy, so we knew.
Yeah, I mean, you walk in the room, you already know what's happening.
Yeah,
so
it's crazy.
That's another, again, kind of just in the whole theme of what we're talking about with, trying to identify subclinical disease that's early, disease where the person doesn't know they have it, a disease where they haven't lost any function yet. They feel fine, they look fine, they act fine because they are fine almost, not really. So, I mean, we could do it just so many different ways now. And again, Carrie, it's the same thing, man. I've got patients. I had one lady that we picked up multiple sclerosis, and she thought she had it, but she wasn't sure, and she was scared and never went and got scanned. She kept delaying the neurology visit. And I said, hey, look, you got MS. And she said, how can you tell that? You're just an eye doctor. I go, that's what eye doctors do. I go, she goes, well, the last eye doctor I went to didn't do this. I go, that's why you're here. Okay, does it all make sense? She goes, yeah, I just, I mean, it's almost like they're flabbergasted, when we start pulling out this technology, because it is still relatively advanced and relatively new, and it has not been incorporated into the mainstream yet, but primarily just because of the cost. You've got to have a busy practice to afford this kind of stuff. Just guys out of school, guys that aren't real busy, it's hard to do. But the people listening to this podcast, I want them to know what's available, and that, we've got technology. If you think there's something wrong with you, man, we could find it in an eye exam. If you know there's something wrong with you, we can make sure it's not getting bad in an eye exam. I mean, there's just, if the doctor's got the knowledge and the technology, there's really no limits to what we can do to help you if there's something wrong with you.
Talk about advanced color vision testing and how that could help us help our patients.
The advanced color vision testing is similar to what we just spoke about with the ERG, the electroretinogram, the functional, and with the eye kinetics. So these are all functional tests. And I said earlier, there's 5, 6, 7 ways we can measure a person's visual function. And I am really a strong proponent and believer of doing that. I think it does. It absolutely gives you a much more complete and comprehensive assessment of the person's visual function when you have obtained data of their vision in multiple domains. So I want to know what the person's visual acuity is. Okay, I want to know that. I hope it's 20/20. I want to know what the person's retinal sensitivity is, because if the retinal sensitivity is decreased, it's a sign of glaucoma. So I may run a threshold visual field examination. Technology has been around for 50 years, but very valuable because of what I just said. So I could measure visual acuity. That's one domain. I can measure retinal sensitivity. That's a second way to measure a person's visual function, because that's what optometrists do. I can measure their retinal function via the speed and strength of the electrical signals going through it with an electroretinogram. That's a third way. I could measure it by measuring pupillary function with the eye kinetics automated pupillograph. That's a fourth way. I can measure it with fancy, sophisticated, computer-assisted color vision testing. That's a fifth way. I can measure dark adaptation with a dark adaptometer that costs $50,000. That's a sixth way. And who's to say what patient has what results? So one patient could have 4 of those tests be normal and 2 of them be abnormal. Is that important or is it not? Shouldn't all 6 be normal if they're normal? So if there's nothing wrong with you, why would you have decreased retinal sensitivity and decreased color vision? I'd have to explain that. I can't just blow that off. I can't say this 50-year-old guy has abnormal color vision. He's had diabetes for 15 years. Those things are not connected, and that's just an ancillary finding. That's just, he's okay. He's okay. His color vision's messed up, but he's okay because he's got 20/20 vision. So the measurement of color vision, and again, it can't be like we were in school with some kind of book of plates, like you're at your pediatrician's office. I'm talking about modern, high-tech, computer-assisted cone threshold testing, cone contrast threshold testing of color vision, sophisticated color vision testing, where I can see subtle changes, minor changes, changes in one eye to the other. That is just as important as visual acuity. If you came in and you had diabetes and one eye was 20/20, like it was the year before, and the other eye was 20/30, and that eye had been 20/20 the year before, I'd have to explain that. I can't just blow that off. I can't say, hey, Mr. Smith, this left eye is fuzzy this year. Hey, I'll see you next year. I'd have to say, hey, you got a cataract, you got glaucoma, this diabetes is messing with you. You had a stroke. I'd have to give them a reason, okay? And the obtaining of the color vision information, along with the visual field information, along with the pupillary response information, all of that blended together is going to give me the best chance at making the most accurate diagnosis. And from the most accurate diagnosis comes the best treatment program. So if I know exactly what's going on, I can tell you exactly how to fix it. If I'm guessing about what's going on, then I'm probably going to be guessing about how to fix it. If I don't know what's going on, And what's worse, if I make the wrong diagnosis, which to me is telling you that you're normal when you're not, that's the worst thing I could do. Is say, hey, you're okay, see you next year. And you got 3 things wrong with you, man, that's the worst thing I can do. So as long as I don't do that, and I want to do these others. So the color vision is simply another piece of the puzzle. And and there's no one piece that's more important than the other to me. You can say some pieces are more traditional than the others. I don't think the electroretinogram is more or less important than the threshold visual field, because in my clinical experience, which is significant, everybody's different. And there's no law that says, or rules or paradigm that says that the threshold field is always going to go first and the color vision is going to go later. So you can have a person where they might have abnormal color vision caused by diabetic neuropathy, and the threshold visual field and the electroretinogram is normal. So what if you only ran 3 tests and those 3 are normal, and you say, okay, patient, you're okay. You know, your visual acuity is normal. I did a visual field test on you, it's normal. I did an ERG on you, that's normal. You're normal. See you next year. You got a color vision test down the hall that you didn't turn on because you thinking this person's normal. If you go do that color vision test, what you're going to find is that 22% of the time, they're going to have abnormal color vision. That is visual loss secondary to diabetic retinopathy. And almost always you'd see neurodegeneration along with that, almost always.
How does it help us with glaucoma color vision?
The same exact thing. You know, the glaucoma, you know, glaucoma is damage to the optic nerve. So the nerve fibers are being damaged and destroyed by the disease process. As enough of the fibers in the macula, because it's got to be in the center of the eye. If those fibers are damaged, then again, you'll have decreased color vision. And it's not really the specific test. So it's not that the color vision test is specific to glaucoma or the color vision test is specific to persons that have diabetes. It's simply a test of visual function, no more or less than the others in my mind. So again, when I have a patient that has an existing disease, let's say diabetes, I want to determine if there's any complications. Do I want to see if there's a loss in 1 domain, in 3 domains, in 5 domains? Man, I'm gonna go 5 domains if I can. Because what if I only go 3 and the 2 I didn't test were the 2 that were abnormal? So now I'm giving now I'm doing the worst thing, which is telling the person they're normal when they're not. And I avoid that like the plague. So I do as many tests as I can, as often as I can, because I think that's the best way to take care of my patient. That's the best way for me to see, is there something wrong with my patient associated with them having diabetes? Yes or no. That's it.
Well, I want to thank Dr. Craig Thomas for joining me today. Powerful words for Dr. Thomas. He loves taking care of his patients. I don't think there's anybody out there that takes care of their patients better than Dr. Thomas. If somebody wants to get in touch with you, Dr. Craig Thomas, how could they do that?
My cell phone is 972-658-0545. That's probably the best way. Just call me, leave a message, I'll call you back.
And if they want to make an appointment, where do you practice exactly?
I'm in Dallas. That's comical. I don't know about you. You know, we're in pandemic mode, man. This is the weirdest time in my entire career. It's you know, if you called my office tomorrow morning and you want me to examine your eyes, like middle of January, okay? It's like that. We're booked out so far ahead. I'm losing money. It's insane. I'm losing patients right now. They can't get in because we're in a, you know, kind of pandemic mode where we are not at 100% capacity. So, I mean, I changed the whole office. We restricted the seating. I had to release one of my associate doctors. You know, a year ago, we'd have 3 doctors in there seeing 80, 90 patients a day. You know, it was like being at the club, you know, could be people sitting on top of each other. It's so loud you couldn't hear. Well, nobody's into that anymore. I'm not, my patients are not, my staff is not. That's the last thing I want. So we schedule, you know, I'm seeing half the patients I used to see. I'm only working 3 days a week. As a matter of fact, Carrie, I'll talk to you about this later. We thought about this yesterday, my partner and I. We thought about going to a schedule like the guys in Louisiana, where we go 5 days on, 5 days off. So I'd work 5 straight days, then I'd take 5 straight days off. My partner would work, 5 on, 5 off, and we would alternate the two of us. And each of us would work 130 days a year. I'm thinking of doing that. It'll be 6-8 months, man, before we get this vaccine. I'm 60 years old. I don't want to get sick. So it's just, it's a weird deal. So, I mean, here's how you get to see me. If you don't want to wait till January to get a regular eye exam, if you want some glasses or contacts, if there's something wrong with you, you got to declare an emergency, and I'll see you tomorrow morning. So all my patients know the secret code. You call in the office, I'm having an emergency. What's wrong with you? I got a spear in my eye. I need help. And they'll say, come now. Okay, I'll see you then. And you come in right there. Otherwise, you're going to wait 2 months to get an appointment.
Well, thanks, Craig. It's powerful words from a powerful person, a great doctor, a great educator. I want to thank you for joining me. Thank you for joining me today. I really appreciate it.
You're welcome. You're welcome. Thanks for asking me.
Presbyopia, I have no idea how to say that.
Presbyopia? Presbyopia might be the ability to see Presbyterians.
There are people who are afraid of the press. I have no idea what it is, honestly. Presbyopia.
A condition in which the eye loses its ability to focus.
Making it hard to see objects up close.
I've heard the bifocal, but not multifocal.
I have never heard of multifocal contact lenses, no.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.